Hi, very good morning. I'm Dr. Janak Patel, MD, General Physician. All my video lectures are mainly for educative purpose. In continuity with the previous lecture series, today we'll be discussing on one of the another very interesting topic and which we come across in our everyday practice. Hence, this lecture will be very helpful to all fourth year students, exam going students, even interns and person who are doing private practice. We come across this particular disorder we call Gerd or we call gastroesophageal reflux disorder. This is the most common which we see in our everyday practice and very common disease. The meaning is very simple. Gastro means stomach, esophageal means from esophagus, esophageal so into esophagus, and reflux means to regurgitate back or flow back is called reflux. Hence this is called even as Gerd, gastroesophageal reflux disorder. The another name which is very commonly being utilized is GORD, and third, a layman type of word, acid reflux, because the acidic material from stomach regurgitate back into esophagus. We'll be discussing under this common heading as usual: definition, etiology, pathophysiology, clinical features, investigations, differential diagnosis and treatment part, and finally the complications. So GERD or acid reflux or gastroesophageal reflux disorders or disease, it is a chronic condition in which stomach content rises and enter into the esophagus. This is because of problem with lower esophageal sphincter closure. Hence, this is called reflux disorder or acid reflux or gastroesophageal reflux disorder or GERD. So very simple: stomach, esophageal is food tubes, reflux is backflow, and disease means abnormal condition. So condition which involves the lower esophageal sphincter weakness and inappropriate opening, leading to reflux of gastric content into the esophagus. And as the acid reflux into the esophagus, it gives rise to burning chest pain. Symptom will worse with recumbent position, and symptoms improves with sitting posture. And certain dietary selection can increase the lower esophageal sphincter relaxation and or delay of the gastric emptying. Hence, this particular factor will increase the symptom signs of gastric reflux. It is very common condition affecting almost 20% of the population. One of the major risk factor is obesity, we call increased body mass index. Some of the dietary factors, particularly like caffeine, chocolates, spicy food, tobacco, smoking, alcohol, they also increase the chance of reflux. And some anatomical conditions like hiatus hernia, that will also increase the chance of acid reflux. Any symptoms of esophageal mucosal damage that results from reflux of gastric content into esophagus, like heartburn, also called as pyrosis, which presents in the form of a substernal burning pain, regurgitation, the person feels bitter sensation in the oral cavity, acidic fluid in the mouth, particularly more during lying down posture or recumbent posture or bending over, and little improvement in a sitting posture. Indirectly, it is more in supine posture, less in sitting posture. If GERD is clinically suspected and there are no indication for endoscopy, empiric treatment can be started, lifestyle modification should be initiated. Now this particular, that is proton pump inhibitor, can be given as an empiric treatment, and person, if he feels improvement in the symptoms and signs, it is in favor of GERD. Now we can divide into two big groups. Normal terms we have already mentioned, GARD, we call GERD or GORD, or reflux, acid reflux, NERD and LPRD. Another way of mentioning is physiological GERD and pathological GERD. Physiological GERD is postprandial. It is lasting for a very short period. Good number of time it is asymptomatic and there are no nocturnal symptoms. While pathologicals are usually symptomatic, we'll find out some mucosal injury, and nocturnal symptoms are very, very common. For this GERD, usually we further use the word like classical GERD, atypical, where you got extra esophageal symptoms and signs, which is usually we use atypical GERD. Then complicated GERD, because of acid reflux, you start getting effect on the esophagus in the form of a Barrett esophagus, which is a pre-malignant condition. So there are few terms: physiological, which is asymptomatic, postprandial, and there is no abnormality; functional, which is asymptomatic and you detect increased pH, increased acid in the esophagus, positive pH study; pathological means there is a symptoms are present and you get a secondary manifestation; and secondary is secondary due to underlying conditions like asthma, gastric outlet obstruction, etc. So as far as the etiology is concerned, we have already mentioned the commonest etiology. One of the common etiology is obesity. Certain diet conditions like fatty material, chocolates, coffee, alcohol, tobacco, smoking, etc. Also during pregnancy there is a high chance of GERD. If a person is taking a large meal, then also there is a very high chance. Drugs, particularly calcium channel blocker, nitrates, antimuscarinics, this relaxes the lower esophageal sphincter. There is also one condition which can increase the chance of GERD, like systemic sclerosis. Then if you once treat the person of achalasia, there is always a chance of lower esophageal sphincter dysfunction, and that can produce GERD, and very, very high association in a person with hiatus hernia. There is one more condition we call as a Crest syndrome, which is very, very common in a group of disorders which we call as collagen group of disorders. C stands for calcinosis, R stands for Raynaud's phenomena, E stands for esophageal motility syndrome, S stands for sclerodactyly, and T stands for telangiectasia. So this is called as a Crest syndrome, and this you see very commonly in the person with a collagen group of disorders like rheumatoid arthritis, periarthritis nodosa, etc. More common with collagen group of disorders. So smoking, caffeine, alcohol, mental stress, obesity, pregnancy, Then even person who has undergone gastrectomy, hiatus hernia, as well as if the angle of his is enlarged, then also this angle of his, if that is enlarged, then also there is a high chance of GERD. So smoking, caffeine, alcohol consumption, stress, obesity, all are pregnancy are the very, very high risk chance for GERD and complications. So smoking, even wearing tight clothes, belts, etc. And if a person is doing exercise with bending, that will also have increased chance of GERD. Lying flat after meal, that also increases the chances of GERD. So smoking damages the mucous membrane. It also impairs the muscle relaxation of the throat. It also increases the acid secretion, and it also reduces the lower esophageal sphincter function and salivation. All this factor will predispose to GERD and damage to esophagus. Even the angle of face, if it is more than 60, the chances of GERD is very high. So that is also one of the factor which is responsible for regurgitation and produces the damage. Even gastrojejunostomy will have a very high chance of GERD. Sliding hernia is another very high chance of GERD. So among the medical condition, hiatus hernia, scleroderma, Zollinger-Ellison syndrome will increase the acid production, and by increasing the acid production, chance of peptic ulcer disease will be high, and indirectly there may be increased chance of GERD. We already mentioned excessive fat, caffeine, pregnancy, obesity, alcohol, smoking, and certain drugs which relaxes the lower esophageal sphincter like calcium channel blocker, nitrates, etc. Among food, we have already mentioned carbonated beverages, chocolates, alcohol, citrus fruits, caffeine containing material like coffee and tea, excessive fatty meal containing tomatoes, mint, and spicy foods. Even you should include tobacco. So these are all the food material which can increase the chance of GERD. Among diet, fatty diet, greasy foods, peppermint, chocolates, carbonated drinks, alcohol, large meal, citrus fruits, onions, and acidic material like tomatoes which can irritate the esophagus. Medications, some of the medications particularly NSAID, erythromycin, calcium channel blocker, nitroglycerin, benzodiazepine, theophylline, narcotics like codeine, etc. can also increase chance of GERD. Now, if we go through the pathophysiology, pressure in the lower part of esophagus, when it is reduced, there is a very high chance of gastric reflux, and defense mechanism is affected. Primary and secondary peristalsis wave will also have effect on acid reflux. Saliva helps to neutralize the acidic material which is present in the gastric content. These are some of the protective mechanisms. Now what is happening? If there is an impaired salivary function, if there is an impaired esophageal mucosal defense mechanism, reduce resting pressure in lower esophageal sphincter, delayed gastric emptying, impaired esophageal clearance, hiatus hernia, transient inappropriate relaxation of lower esophageal sphincter, increased gastric acid production, pyloric incompetence and duodenogastric reflux, etc. All these factors will have a very high chance of acid reflux. So putting it together, so impaired mucosal defense, decreased esophageal clearance of acid and lying because of lying down flat and diet like alcohol, coffee, spicy food, etc. Also there is a decreased peristalsis, salivary bicarbonate is reduced, so to neutralize that acid factor, that factor is reduced. As far as stomach factor is concerned, increased acid output because of smoking, coffee, NSAID, aspirin, steroids, etc. Even H. pylori infection is responsible for that. When intragastric pressure is elevated either because of obesity or pregnancy or lying down flat or doing an exercise, bending forward, etc. Fat will reduce the gastric emptying, so delayed gastric emptying either because of obesity or because of some drugs also. If there is a bile reflux from duodenum into the gastric content, and impaired lower esophageal sphincter, transient lower esophageal sphincter relaxation, there is a pressure in the lower esophageal sphincter is reduced either because of drugs or because of other pathological conditions, even hiatus hernia, etc. will predispose to Gerd. So all those factors again shown here very nicely. Obesity and dietary factors will have effect more on lower esophageal sphincter, defective esophageal clearance, hiatus hernia, reduced tone in a lower esophageal sphincter, delayed gastric emptying, increased intra-abdominal pressure, increased acid production, etc. all will be responsible for Gerd. So this becomes very, very important factors. In hiatus hernia, the lower esophageal sphincter is often low. There is a gastric pouch with intrathoracic reservoir. Diaphragm, there is no esophageal pinch at the level of diaphragm. All these factors will be responsible for Gerd. Erosive esophagitis, reflux gastric content back to the esophagus due to pathological reflux or physiological reflux. Pathological reflux is associated with symptoms or mucosal injury. Often occurs during night time because during night person is in a recumbent position. Well, physiological is usually after taking a heavy meal or a large meal. It is short lasting, by and large asymptomatic, and rarely occurs during sleep. Now there are two mechanisms what we call, one we call as a erosive esophagitis and second we call as a non-erosive reflux disorder. The meaning of non-erosive reflux, short form we also called as NR, non-reflux. So endoscopically there is negative for reflux disease, is characterized by presence of troublesome symptoms of GERD without visible esophageal mucosal injury. So that is called non-erosive. And if you demonstrate endoscopically there is a damage to the gastric mucosa, esophageal mucosa with or without troublesome symptoms, it is called erosive gastritis reflux disorder. Now in that erosive there is a local inflammation, erosion and sometimes even ulcers, and later on you will start getting changes in the mucosa in the form of a Barrett esophagus. So this will be typical. So it is divided into pathological and physiological. Pathological, you can have a non-erosive reflux disease and erosive reflux esophagitis. And when you start getting a changes in the gastric mucosa replaced by other group of cells, that is epithelium is continuously damaged and replaced by columnar cells, which has got a very high chance of esophageal cancer, we call as an adenocarcinoma. This is called as a Barrett esophagus. I am not expert in a histopathology. If you are interested, you can go through your at leisure time. Initially, you start getting a damage, superficial coagulative necrosis in a non-keratinized squamous epithelium. Then there is a thickening of the basal cell layer, elongation of a papillae, inflammatory cells, and transformation of the squamous cells, we call as a Barrett metaplasia. Reflux acid may cause a direct injury to the extraesophageal structures like larynx, pharynx, even dental. So you can get laryngitis with dysphonia. You can even get aspiration of gastric content into the lung, and that will produce chronic cough, pulmonary fibrosis, asthma. Larynx will produce laryngitis and dysphonia. You will have a bad dental hygienes. You can have inflammation of pharynx, and even some person can develop otitis. These are called extraesophageal manifestation due to acid reflux. So asthma is quite common. It can also involve pharynx and larynx, and acid reflux into trachea can produce spasm and asthma-like symptoms. Hartmann is classical symptoms of GERD. Substernal burning pain and or regurgitation, postprandial symptoms, aggravated by supine posture, relieved by sitting posture, and also promptly relieved by antacids. This will be peculiar in case of a GERD. Person will all very good number of time present with a retrosternal burning pain, globus sensation, little nausea, water brass, odinophagia, chronic cough, hoarseness, wheezing, dysphagia. This particular dysphagia, chronic cough, hoarseness, wheezing, odinophagia, all these are extraesophageal symptoms because of acid reflux. You can see from the percentage of the symptoms, almost in 80% of the time it is heartburns, regurgitation in 54%, abdominal pain in 29%, while cough, dysphagia, hoarseness of voice, belching sensation, etc. around 20 to 25% of the people. Aspiration, wheezing is in a very small group, but still that is an extraesophageal symptoms. Classification of GERD can be one way, we already mentioned, pathological and physiological, erosive and non-erosive. Another way is esophageal symptoms and extraesophageal symptoms. In esophageal symptoms, symptomatic syndromes like typical reflux syndrome and reflux chest pain syndrome. While syndrome with esophageal injury will have a reflux esophagitis, stricture formation, Barrett esophagus, followed by adenocarcinoma. Among extraesophageal symptoms or syndromes, established and proposed. Among established, reflux cough syndrome, reflux laryngitis syndrome, reflux asthma syndrome, and reflux dental erosion syndrome. So these are all extraesophageal involvement of the different structures. apart from esophagus. While pharynx, sinusitis, idiopathic pulmonary fibrosis and recurrent otitis media is proposed association, and good number of time treatment for acid reflux does gives rise to good recovery. So you got esophageal symptoms, extraesophageal symptoms. Among esophageal, heartburn, dysphagia, odynophagia and regurgitation. Even water brass, etc. are described symptoms. While extraesophageal cough, particularly nocturnal cough, chronic cough, wheezing, hoarseness of voice, epigastric pain and non-cardiac chest pain. These are some of the symptoms in extraesophageal. Commonest symptom being heartburn, that is person will complain of burning chest pain, retrosternal and occurring after a heavy meal or after alcohol, after spicy food, in supine posture, bending forward, etc. and partially relieved by sitting posture, antacids, etc. Exaggerated by lying down posture, eating late in night, certain dietary choices, particularly chocolates, caffeine containing materials, spicy food, alcohol, NaCid, etc. When you eat too quickly also, there is a little high chance of acid reflux. You can give a therapeutic challenge like proton pump inhibitor. The person will improve as far as the symptom is concerned. So symptom will improve with sitting up posture, antacids, proton pump inhibitor, eating more slowly and avoiding certain foods and beverages. That will be in favor of Gerd. So regurgitation, acid taste, damage to enamel of the teeth, this will be extraesophageal symptoms. Commonest symptoms is heartburn, or we call pyrosis, and secondary to the damage to the esophagus, stenosis, dysphagia, and damage to the larynx and aspiration, chronic cough, hoarseness of voice, and all this will worsen more with lying down posture. Reflux esophagitis will also produce inflammation and small ulcer in a esophagus. Then later on there will be esophageal sphincter, will be having stricture formation, changes we call Barrett esophagus, and last is adenocarcinoma. And once the person starts getting this inflammation and ulcer, there is a spasm, there is a stricture formation, person will also complain of dysphagia. So esophageal ulcer, odynophagia, painful ulcer. We already mentioned most common symptoms: heartburn, regurgitation, acid taste in the mouth, etc. More in lying down posture and worst at the night, and typically depending on the food, type of the food, fatty food, spicy food, chocolates, caffeine, beverages, alcohol, NaCid, etc. will worsen. Dysphagia is less common, but whenever the person starts complaining of dysphagia, means already the esophagus is getting badly damaged. So pain while swallowing, sore throat, choking sensation, coughing, gurgling or regurgitation of food or stomach acid, and person also feels as if the food is stuck behind the sternum, burning sensation behind the sternum, that is we call water brass. Even person when he regurgitates into the larynx, he will complain of hoarseness of voice, dysphonia, etc. Some of the other symptoms like nausea, chest pain, sensation of lump in your throat, wearing of the teeth, bad breath, etc. These are all extraesophageal symptoms. Recurrent cough, breathing difficulty, chest congestion, lung inflammation in the form of person will also have wheezing. These are all in what we call as extraesophageal manifestation. And secondary to aspiration, person can develop even pneumonia. So regurgitation, belching sensation, coughing, hoarseness of voice, quite common, sour throat in the mouth, excessive salivation, dental problem, nausea, epigastric pain, dysphagia, odinophagia, that is painful swallowing, almost similar to dysphagia, but dysphagia is difficulty in swallowing and this is a painful swallowing. So among extraesophageal, maybe pulmonary, maybe ENT, we already mentioned majority of the time, asthma, aspiration pneumonia, chronic bronchitis, pulmonary fibrosis. While among ENT, hoarseness, laryngitis, pharyngitis, chronic cough, dysphonia, sinusitis, subglottic stenosis, laryngeal carcinoma also is partly secondary due to acid reflux, chest pain, dental erosion, otitis media, etc. There are some alarming symptoms which will suggest that there is increased damage to the esophagus in the form of Barrett esophagus, stricture, or maybe adenocarcinoma. If person is having dysphagia, early satiety, GI bleeding, odinophagia, persistent vomiting, unexplained weight loss, iron deficiency anemia, choking sensation, and even after an empirical treatment for full therapeutic dose, person doesn't get response. And if age is less than 45 and there are respiratory complications, do think of alarming symptoms and do investigate for Barrett esophagus, esophageal sphincter, or adenocarcinoma of esophagus. So these are all red flag signs: chest pain, choking sensation, dysphagia, GI bleeding, odinophagia, persistent vomiting, severe abdominal pain, weight loss, unexpected weight loss, etc. Immediately refer to a specialist. Now, how you undergo investigation? There is one thing which is said: whenever you suspect a GERD, empiric treatment is one of the method by which you can suspect that GERD is possible. So you give an empiric treatment with proton pump inhibitor for an adequate period of time, and in person shows a dramatic response, do think in terms of GERD. Investigations wise: barium swallow, upper GI endoscopy, esophageal manometry, 24 hours ambulatory esophageal pH recording, and gastric emptying study to find out evidence of gastroparesis, etc. will be very, very useful in person suspected to have GERD. Classical presentation and response to empiric treatment is one of the clinical clue. Upper GI endoscopy is very, very helpful to confirm whether it is erosive gastritis or a non-erosive gastritis. Is there any chance of Barrett esophagus or adenocarcinoma? Is there any stricture? Even it will help to rule out hiatus hernia, etc. Ambulatory 24 hours pH monitoring is also one of the very, very useful tool. Barium swallow and barium meal will be helpful to rule out hiatus hernia, as well as sometime to find out what we call as ulcer, adenocarcinoma, etc. Esophageal manometry will help to find out the motility disorders. Bernstein's test. This is a test to find out the heartburn is caused by acid in the esophagus. The test involves the dripping a mild acid similar to the stomach acid through a tube placed in the esophagus and see whether the heartburn occurs or not. This is one of the tests which can be done. ECG is mainly to rule out ischemic heart disease if you are suspecting a coronary artery disease in a person with a retrosternal chest pain, because it is a close differential diagnosis of Gerd. So 24 hours pH monitoring, X-ray, barium, meal, endoscopy and biopsy. Biopsy will be very, very helpful to rule out Barrett esophagus and also to find out is there any chance of adenocarcinoma. Endoscopy is absolutely necessary if there are alarming symptoms, we have already mentioned before. If there is no improvement by empiric treatment, if we are suspecting any particular pathology and you are planning for surgery, endoscopy should be done before a pre-operative evaluation. And if you want to rule out Barrett esophagus or adenocarcinoma, endoscopy is a must. There are other methods also like wireless or catheter-free esophageal pH monitoring, which can be done, and that will help to rule out 100% chance of acid reflux. Esophageal manometry will help to find out the lower esophageal sphincter disorders by doing a pressure studies, and also it will help to find out the severity also. Among differential diagnoses, always keep it in mind: achalasia cardia, esophageal motility disorders, esophageal malignancy, esophageal ulcer, and do not forget ischemic heart disease, coronary artery disease. I am skipping over this particular part because otherwise it will become very long. One of the close differential diagnoses you should rule out is ischemic heart disease. As far as the treatment is concerned, you must have lifestyle modification, patient-directed therapy, acid suppression by proton pump inhibitor or H2 receptor antagonist, pro-motility therapy. If does not get response and if there is a very high chance of Barrett esophagus proven on biopsy or suspected adenocarcinoma, surgery may be helpful, or sometime even endoscopic treatment will be helpful. Try to eliminate the symptoms by giving empiric treatment and symptomatic treatment. Always see that esophagus does not develop damage, and you should decrease the chance of complications, or we call prevention of complications, and maintain them in a remission. This is a must. So prevention, lifestyle changes, medication, followed by surgery. So most important part first is lifestyle changes. Among lifestyle changes, reduce weight. While lying down flat, elevate your head, side, bed. So elevating the head of back side will be very, very helpful. Avoid the drugs which increases the reflux, like theophylline, anticholinergic drugs, calcium channel blockers, etc. Eat small meals, no late meals, reduces fat, reduces chocolates, tea, coffee, spicy foods, fried foods, etc. Avoid alcohol, coffee, beverages, etc. Stop smoking. All these are part and parcel of lifestyle modification. So lifestyle changes also includes maintain your BMI, reduce intra-abdominal pressure, avoid spicy, fatty food, chocolates, coffee, alcohol, etc. and keep head elevated like this while you are in a supine posture, and avoid all these foods. Antacid will help to neutralize the acid, Proton pump inhibitor will decrease the acid production. You can use the prokinetic drugs which will increase the chance of gastric emptying faster. There is also little benefit by GABA agonists like baclofen, which inhibits the transit of lower esophageal relaxation. So lifestyle modification, dietary modification, physical therapy, etc. is very, very helpful in GERD. So the position in which you sleep, have a head elevation, avoid alcohol, nicotine, coffee and calcium channel blocker, diazepam, biphosphonates, nitrates, etc., NSAID, steroids, all those drugs should be avoided. Eat several meals, small meals instead of big meals. Avoid spicy food. Don't lie down within 2 to 3 hours after eating. Avoid stress and always have head elevation. Foods to be avoided is citrus fruits, what we call as the acidic foods. Alternative to non-citrus, non-acidic fruits, try to consume those particular material like apple, melon, pears, etc. instead of oranges, limes, lemons. Those foods should be, caffeine should be avoided, chocolate should be avoided, spicy food, fried food should be avoided, high fat diet should be avoided, processed food should be also avoided, tomatoes, onions, mint, excessive salt, alcohol, beverages, particularly carbonated beverages should be avoided as much as possible. All this should be avoided. Spicy food, fatty food, fried food, garlic, caffeine, tomato, citrus fruits, onion, freezing, chocolates, dairy products, all this should be avoided because this predisposes to GERD. So any person who is seeking for heartburns, this is the algorithm by which you can approach. I am skipping over this particular because majority of the thing we have already discussed. At your leisure time you can go through. It is a nice chart. This is another very simple chart. Any person who comes to you with a typical symptoms, first use antacids. You can add proton pump inhibitor in a full therapeutic dose for full period of time. If a person gets good response, proton pump inhibitor is maintained. You can use H2 receptor antagonist and antacids. If there is a poor response, reconsider the diagnosis. You can go for investigations like pH monitoring, esophageal manometry, endoscopy, etc. If it is normal, then reconsider the diagnosis again. If it is positive, now you can go for what we call as a surgical intervention like fundoplication. So any person with a heartburn, first start with H2 receptor antagonist or proton pump inhibitor. If H2 receptor antagonist is taken, give it BID. If there is a good response, yes. If there is a frequent responses, then you will have to think of again going to proton pump inhibitor. If proton pump inhibitor is taken, if there is no response, proton pump inhibitor is given, and if there is a relapse, proton pump inhibitors are used. Now proton pump inhibitor, once it is used, if there is a good response, maintain the therapy at the lowest effective dose. If symptoms persist, now you can think of further reinvestigating and trying to find out any complications also. If there is no response, increase the dose to maximum BID or QID doses. If there is a good response, maintain at the lower therapeutic dose. And if there is no response, then pH monitoring, manometry, endoscopy, biopsy, etc. So usually while endoscopy, we divide into different groups: reflux esophagitis, non-erosive reflux disorder, and complicated reflux disorder. These are the words which are being commonly being used. So if there are alarming symptoms, straightforward go for endoscopy. And after giving an empiric therapy, if person does not respond, also go for endoscopy. And then depending upon the endoscopy, non-erosive variety, reflux esophagitis means there is definitely clear-cut reflux esophagitis, and complicated means either there is a Barrett esophagus or adenocarcinoma, or you are suspecting some other complications. Always go for further investigation and treatment. So antacid, H2 receptor antagonist, prokinetic drugs like domperidone, cisapride, etc. Proton pump inhibitor like omeprazole, lansoprazole, pantoprazole, rabeprazole, esomeprazole can be utilized, should be given in a full therapeutic dose for full period of time. So this is a nice slide, so I'll take little time. If the person is more than 50 years age or symptoms more than 5 years along with the cancerous factors, or sudden alarming symptoms like weight loss, anemia, hematemesis, melena, persistent vomiting, dysphagia or odynophagia, you have to straightforward go for surgical intervention, investigation and surgical intervention. Now, before we go for surgical intervention, endoscopy, if there is no esophagitis, consider other disorders like achalasia, gastroparesis, etc. And that should be further investigated by esophageal manometry, esophageal pH, gastric emptying time, endoscopy, biopsy, etc. And if there is a clear-cut esophagitis, treatment should be started according to the diagnosis and try to find out the response to your treatment. Also, there will be certain causes of esophagitis like pill-induced esophagitis, autoimmune skin disorders, Jollinger-Ellison syndrome, eosinophilic esophagitis, Barrett esophagus, all these things should be ruled out. So this is one simple way of approach. And when the person is already having a GERD with no alarming symptoms, no cancerous signs, and symptoms are less than 5 years, in a male, in a person with less than 50 years, first always give proton pump inhibitor for minimum 2 months. Full trial should be given. Now there will be few possibility. If symptom persists, then go for endoscopy, pH monitoring, manometry, etc. If the symptoms are controlled, good response, continue with the therapy. If symptoms are refractory, change the proton pump inhibitor, increase the dose of proton pump inhibitor and look for the response. So proton pump inhibitor should be minimally given for 8 weeks. OD dose. If person doesn't get response, further diagnostic investigation or increase the dose, that is twice a daily therapy, partial response twice daily, or switch to the different proton pump inhibitor. Say person is on omeprazole, switch over to pantoprazole or lansoprazole, etc., or the other way around. If there is a good response, then continue with the treatment for minimum 8 weeks, and even after that you might require a treatment. So proton pump inhibitor, H2 receptor antagonists are for reducing the acid production, to increase the gastric emptying, prokinetic drugs, and to neutralize the acid, antacids are very, very important. And the medications which strengthens the lower esophageal sphincter may be utilized, and avoid the material which decreases the lower esophageal sphincter too. So in general, the person with episodic heartburns, occasional meal provoked heartburns, frequent moderate to severe heartburns, etc. Alarming symptoms present, directly refer to a specialist. Here you can have H2 receptor antagonist prior to meal, or you can go for proton pump inhibitor if the symptoms are severe. Give it for minimum 2 weeks. If symptom resolves, continue for further, and symptom does not resolve, go for investigations. So the person whom you give an empiric treatment and still the person has got symptoms interfering with that quality of life, lifestyle changes given, medications are given for adequate period of time, and person is not willing to take treatment for long period, you can go for investigative side, that is endoscopy and further. Now if the person is refractory to treatment and there is alarming symptoms, after investigations, if person has got gastrointestinal indications, failure of optimal medical treatment, non-compliance, high volume reflux, benign strictures, esophagitis, Barrett esophagus, etc., you will have to go for surgical therapy. And one of the classical surgical therapy is fundoplication, that is plication of the fundus part of the stomach, which is called complete plication, that is called Nissen fundoplication, or partial fundoplication. These are the words which are being utilized. So fundoplication complications, intraoperative damage, gas bloat syndromes, slip Nissen or telescope phenomena, etc. The person who has got dysphagia, especially to solid foods, will be very, very common as a complications of fundoplication. Abdominal bloating, there is something called as a telescope phenomena or slip Nissen, or it is also called as a slip Nissen. So this particular portion gets bulged up, stomach part, then person will not be able to take the solid foods. There will be increased flatulence, inability to belch, etc. will be the common symptoms secondary due to fundoplication. There is also one variety we call as a partial plication, and this is total plication. So two types of surgery depending upon the indications. Hiatus hernia, a part of the stomach slips through the diaphragm, and that may be one of the factors which will be responsible. You will have to go for endoscopic treatment part, which can be done at the level of lower esophageal sphincter, either by thermal energy or mechanical or neural treatment. So endoscopic suturing, endoscopic plication is one of the treatment which can be done in a case of a lower esophageal sphincter. So bicompatible materials are also being utilized for lower esophageal sphincter. Then in a case of a stricture, you can go for balloon dilatation. It is called through the scope balloon dilatation. Through the scope balloon dilatation. And whenever there is a Barrett metaplasia, non-dysplastic or dysplastic variety, always get a biopsy done and look for malignant changes. And you can go for endoscopic resection or laser treatment. So laser treatment, electrocautery or photodynamic therapy is an ablative therapy for Barrett esophagus. or you can go for endoscopic mucosal resection. So endoscopy, if there is a carcinoma, resection is a must. High grade dysplasia, resection. If there is a low grade dysplasia, medical treatment, wait for some period of time. If dysplasia disappears, you can go for repeat investigations and follow up. If it is benign and if it is symptomatic, medical treatment. If it is asymptomatic, regular follow-up at a yearly interval or half-yearly interval. Medical treatment, if it is successful, go for a regular follow-up and yearly interval. And if it is unsuccessful, anti-reflux surgery like fundoplication. Complications of GERD, esophagitis, esophageal sphincter, Barrett esophagus, and adenocarcinoma are the commonest complications. So, ulcerative colitis or erosive gastritis, esophageal sphincters, Barrett esophagus, adenocarcinoma. And there are a lot of extra esophageal complications in the form of chronic cough, laryngitis, reactive airway disease, recurrent pneumonia, pulmonary fibrosis, asthma, otitis, etc. So, esophagitis, esophageal ulcer, Barrett esophagus, aspiration pneumonia, iron deficiency anemia, esophageal sphincter, adenocarcinoma are the big list of complications. Spectrum of disease theory, non-erosive disease goes to the erosive, to the Barrett esophagus, and finally to adenocarcinoma. So I end my lecture here. Thank you very much for taking out time. I know that your time is valuable and I appreciate you for spending some of the time with me. If you like this particular lecture, don't forget to press button like, have a thumbs up, you can share with your friends, and I feel this will be very helpful to you in your everyday practice, because every now and then we see a person with the symptoms which are in favor of reflux disorders. So try to suspect this particular group of people, take a good history, proper examination, proper investigations, full therapeutic dose of proton pump inhibitor as an empiric therapy, followed by, if required, endoscopy, pH monitoring, esophageal manometry. All this investigation will be helpful, even gastric emptying time to rule out gastroparesis. And if you diagnose them early, treat them properly, and give them a proper treatment, you can avoid Barrett esophagus, adenocarcinoma, esophageal sphincter, which are a bad complication of GERD. So do look for these conditions. So once again, thank you very much for taking out time. See you in next lecture.